am very pleased to introduce our speakers today. We're going to be talking about using data to make sports safer toward a National Registry of Catastrophic Youth Sports Industries. And this is a presentation based on the BCTR Innovative Pilot Study Grant that these skiers received. So it's a really nice way for us to see sort of how the money that they received through the pilot grant was used in some really innovative examples of translational research. So our presenters today are Bill Block. Bill is the director of CISR, which is the Cornell Institute for Social and Economic Research, which he's been since 2008. If you're not familiar with CISR, it's a fabulous resource that we have here at Cornell. It's a computing resource. It also allows access to restricted data, which is something really, really unique we have here at Cornell, and a really rich data archive as well. We also have Warren Brown, who's a senior research associate at CISR, and before that, directed Cornell's program on applied demographics. And so they are going to be talking about what they've been doing on making sports safer. So thank you.
Thanks, Rachel. Thanks, Rachel. We're really glad to be here today. I should acknowledge that a colleague, Dan Gaze, is at the Mayo Clinic in Rochester, Minnesota. He's joining us electronically, so he'll be on the phone and hopefully joining the talk at opportune moments. Dan, can you hear us okay?
Yeah, I can hear you fine, if you can hear me.
Terrific. I think we can. Good. Let me start by thanking the BCTR for funding this work. I had never personally been involved in a data set project that could actually have an impact on physically improving someone's lives. We don't usually do that when we work with unemployment statistics and marriage records and things like that. So this was a pretty neat opportunity. And when I saw the opportunity open up, I jumped on it, and BCTR was kind enough to fund it. So I'm really appreciative of that. And we're very excited to talk about what we've been doing with the pilot funding. I think you'll conclude that we've done some good work in the past year, and we've got plans for going forward further. So we're excited to be here, and thank you very much. Let me start out by showing you the outline of what we're going to talk about today. First, I'll talk about what inspired the research. It's sort of a personally compelling story. Then, as soon as we got started doing this new interdisciplinary translational research, we ran into a roadblock and got stuck, and we'll talk a little bit about some of the lessons we learned. Then, most importantly, we'll talk about the research. We've divided this part of the talk into two phases. What we did first in St. Paul at the Minnesota Department of Health, and then subsequent work where we're attempting to grow the effort. And finally, at the end, hopefully there'll be plenty of time for comments and questions and discussion. And Warren and Dan, feel free to jump in at any point. I do have a very informal presentation style. If I'm very open to questions along the way. I'm not at all troubled by that at all. So let me tell you a little bit about the inspiration for this story. It involves a fellow named Jack Jablonski. Jack was in 2011. He was a 16-year-old hockey player in Minnesota. That's, of course, if anyone who knows me knows I come from Minnesota. I personally play hockey. I grew up playing hockey. My kids play hockey in Ithaca. At the time, my daughter was an 8th grader on the high school team, playing on a second team in town. My son was a squirt travel goalie. I was playing in the adult league. So I was following a story in the Minneapolis paper, and Jack was injured. And there was, this was late December 2011, and it was a pretty compelling story. An opposing player hit him from behind, not a vicious hit, ends up hitting the boards, and as occasionally happens, catastrophically injured his spine. And I'm following the story, and suddenly, early in January, there was this editorial, like, using data to make sports safer. I thought, hey, I know about data. I like hockey. So I was reading it, and it was a lengthy quote from a fellow named Michael Stuart. He's a doctor at the Mayo Clinic, very impressive credentials, vice chair and professor of orthopedic surgery at the Mayo Clinic, co-director of the Sports Medicine Center at Mayo. Very interesting to me because I'm a level 4 trained hockey coach in USA Hockey. He's the chief medical officer for USA Hockey. That's the main organizing body for youth hockey in the United States. And wow, he's the physician for the 2010 USA men's Olympic team. So this guy had really good credentials. And I was reading the editorial, and this is worth reading directly for those of you who can't read it, maybe in the back. The quotation from Mike in this editorial said, "Unfortunately, the United States does not have a central registry of sports injuries. other countries with national health care have a better handle on these injuries because they have records that can be accessed. It's a very difficult task to come up with very good data which can be used to make decisions on rule changes that can affect everyone. It would be wonderful if we had that opportunity. And this was from the January 5th, 2012 Minneapolis Star-Tribune. So I thought, wow, I should, email this guy, but he's going to think I'm, I didn't even think Mike would respond. But I thought about it pretty carefully and put together an email, dropped Cornell's name into the email, and things like that. And, in 45 minutes he responded and said, I'm very interested, please get in touch, and we'll go forward. So that led to us learning about the Mayo and USA Hockey pilot data project on catastrophic injury registry for ice hockey specifically. And it's a clinical trial. Mayo partnered with USA Hockey on this data registry, and it's trying to gather data on all catastrophic and potentially catastrophic injuries in ice hockey at all levels of ice hockey. So youth, NCAA, Division III, adult hockey. It was taking data in via phone. I saw an injury, I'm reporting it over the phone or email, custom Google searches, automated Google searches looking for search terms, looking for hockey injuries. The data itself is from 2008, I think it continues to 2013. When we received the data in 2012, I think it had about 45 entries, and these are sobering entries. I believe there's a death or two in the data set. So these are significant injuries in ice hockey. Interestingly, there were 5 from Minnesota, and I was really wondering. I didn't know what the proportion would be. And Warren and I argue constantly about what the 0 from New York State means. In my opinion, being a staunch Minnesotan, it means New Yorkers don't know how to play hockey. I think Warren has a differing...
I think New Yorkers can skate better.
Yeah, so we're not really sure what that means. And importantly, Dan is the study coordinator. Dan, who's joined us on the phone, is the coordinator of this effort. So I think the first task that we set out to do, and this is where I was trying to help Mike Stuart, now Dan, with this project, is we thought that there was a better way to go about gathering data on catastrophic injuries, and that's what we set out to do initially. So we proposed this pilot project to BCTR. We put together a project team involving some folks from Sizer, including Florio Arguilis up here in front. Suzanne Priere knows a lot about disability. She's the director of the Employment Disability Institute. We included some partners at Mayo and also at Weill Cornell and the Hospital for Special Surgery. And we made this proposal, and it was, we're thrilled when it was funded. And then work ground to a halt. As soon as we tried to get started with this effort, we discovered that when trying to bring social science data types together with medical data types, it's first of all a completely different language. And one needs IRB approval for this kind of work. And when we approached the Mayo Clinic, we're normally dealing with secondary analysis, data that already exists, reanalyzing it. Oftentimes research with this kind of thing is exempt from IRB requirements. Well, Warren can also talk about the data sharing agreement.
So Cornell IRB looks at the data sharing agreement that Mayo had sent us, says no problem. We describe what we're going to do. Yeah, fine. And the folks at Mayo, the IRB officer, would puzzle over our application for a while, ask us further questions, puzzle over it, ask us further questions. And what it really boiled down to was secondary analysis of existing data where you're not going to interact with patients was, for this IRB officer, was like, wait a minute, you're not going to inject people with something, you're not going to do a medical procedure. So the final conclusion was, well, you're exempt because that's not research.
So we're officially here reporting on our non-research project.
So secondary data analysis is not research, just in case you thought it was.
We made a couple of non-research trips that BCTR has paid for.
But you can kind of appreciate from that perspective. It just took a while. We were sort of talking past each other.
Right. And so what we originally had hoped for was a July 1, 2012 start date. And couldn't believe it when it turned to the next calendar year before the work actually started. So early in January 2013, we had our first project meeting, and that was when Mayo's IRB had determined we were exempt, and we were thrilled because we could move forward. But that's a good lesson, I think, in terms of just translational research. You're taking from A and putting it into B, and you're likely to run into issues. And that was a great lesson for us to learn. We are involved in interdisciplinary things a lot, but clinics are a whole other thing for us, right, at Sizer. So at any rate, phase one, the first part of the work that happened in January, and this is where I was really thrilled when Dan provided the content for this slide, because he put the same things on the slide that I would have done. So Dan, I don't know how we want to present what's in slide one. If you want to jump in here and talk about the meeting. At the meeting, we met in St. Paul. It's about 70 miles from Rochester. Dan drove up, and then we met at the Minnesota Department of Health, and they were there to work with us on some Minnesota injury data. Dan, do you want to talk about this slide?
Yeah, no, that'd be fine. And the first two objectives that you guys can see were set forth by Warren before we met, and he was unable to join us, but it was good that he put these in place because it streamlined basically what we were going up there to do, comparing the Minnesota-based entries from Mayo USA Hockey Catastrophic and potentially Catastrophic Injury Registry to what they currently had in the state of Minnesota within their injury data access system. So we were looking to see if injury records that were captured for Minnesota residents that were in my database were also present in the MIDAS database, and then conversely, we were looking at, where were if there were entries that they came up with based on our search terms, and they were able to classify a handful of our terminology into ICD-9 coding. What were we missing? Anything? And the outcome was pretty positive on the fact that we found 4 out of the 5 incidents that were in my database, but we also missed 46 based on medical record searching for ICD-9 coding and also narratives that exist within the discharge notes. Another thing that came...
Let me interrupt just a second.
Sure.
ICD-9, for those of you who might not know, International Classification of Disease, and it's the 9th iteration. We're now somewhere between the 9th and the 10th in terms of adoption, but it's trying to set up standards for diagnosis of what is the problem with this person.
Yeah, Dan, let me jump in here, too, a little bit of preparatory comments. The assumption here, right, is that these are catastrophic injuries. It's not where you bump your toe and you may go to the doctor and nothing happens. Catastrophic injuries, we assume, will end up in the hospital. So what exists in 43 states are really good hospital discharge data. When you're discharged from the hospital, you leave a medical record that the states collect. It's administrative data. And that's what we're searching for when Dan says we found in the Minnesota Injury Data Access System, that data set MIDAS. Those are hospital discharge records where the assumption on our part is all we have to do is figure out if it's a catastrophic injury and figure out then if it's sport-related. Then we can sort of back into the data that Dan was gathering via phone and Google and email, and that's what we're trying to assess.
Yeah, luckily we are able to drill down sport-specific because of a newer addition, these injury-specific codes, E-codes, and you can search by sport participation. And fortunately for us, there's one code specifically for ice hockey. So that was the way that we could kind of separate all the catastrophic injuries to the particular sport and then determine based on the mechanism or the information of injury that we had, even though it was de-identified, we could narrow it down to particular injuries based on my reports and what they were able to match up with. So this was, I mean, the way that I was gathering information seemed as good as I could do at the time, but the interaction with both Warren and Bill and also the folks at the Department of Health kind of opened both my eyes and Dr. Stuart's eyes to how much more we could do with data. So it was a good interaction, and they seemed completely on board with what we were doing and were willing to assist any of our projects going forward as long as, provided we're going to stay with Minnesota data and things like that because of the statutes that are in place.
Yeah, I was very happy to see the reception by the Minnesota Department of Health. We were expecting, I think, one analyst to join us for the day, and we had 3 analysts all day, and including their boss for 2 hours in the morning and at lunch. So they really did give us the attention that really was appreciated. And then we're enthusiastic about helping Mayo. One of the key things is these ICD-9 codes were extended in, was it 2009? And became, there are more specific ones. And so you do get coding by medical coders, usually for insurance purposes, about injury is on an ice sheet, it's a fall, and you get all these specific codes for insurance purposes. And one of the unknowns is how, if you ask a medical coder, oh yeah, these codes are always, we're really careful with the codes. Well, I think that's actually an open research question. I doubt that all coders are equally careful about it. We know from working with one of our colleagues, Stephen Lyman, at the Hospital for Special Surgery, some hospitals don't use them, some do, and some do, a mediocre job and things like that. So there's a broad range. And what MDH was thrilled about was they were willing to go go to medical coding conferences and stress the importance of implementing these codes, which was terrific.
And I guess the one major conclusion that we left with, and it's pretty obvious to us after meeting, was that you really did need to use these discharge records to get a nice data set for the injuries that we're interested in on a catastrophic, in a catastrophic nature, because otherwise you're kind of left with just public record searches, and as we can see, it's not as 100% or even 90% as accurate as we want it to be or need it to be in order to further investigate all the different injuries in sports and mechanisms of injuries and things like that. So it was definitely worth the trip. It would have been nicer if it was in July, though. It was kind of a crummy day. So.
Yeah, so it rained that day in the middle of January. Go figure. So the conclusion of this meeting, I think, was we had determined that, hey, there's a possible fruitful path that we could follow to get some better data on these injuries. So we left thinking, we obviously can't go from where we are to a national registry. Why don't we try 2 states, and we have good connections on an equivalent data in New York State, Sparks data, and Minnesota. And so why don't we expand to all sports, all catastrophic injuries in all sports in 2 states, and see what we might do with that. So that's where we left this meeting in January. And then a very exciting opportunity opened up from NIH. The title of a call came out entitled Pilot Projects on Sports-Related Brain and Spinal Cord Injury. And the call was, the language of the call specified this is a broad call. We think there's a lot to figure out in this area, many unknowns. We're looking for medical experts and non-medical experts, many disciplines to converge on this problem. And we have prepared an R21 proposal, $275,000 in direct funds. It's due on Tuesday, next Tuesday. So it's already into OSP.
What are you doing here?
Yeah. This presentation came together very quickly because my internal deadline was yesterday at OSP. The night before, about 9 o'clock, we got it in. So yeah, there's an R21 that's sitting at OSP that is about ready to go, and we're working with our colleagues to prepare. So we want to tell you about that. That's sort of phase 2. We think that the work, it's very nice. The team that we put together, Weill Cornell Medical and Hospital for Special Surgery in New York City, they're going to take on AIM-1, be responsible for that. We'll be responsible at Sizer for AIM-2, and the Mayo Clinic and Dan and company will be in charge of AIM-3. So it's a very collaborative proposal. Each partner has very significant work to do. It's not one of these where you just stuck some names on to make a call to collaboration. It truly is collaborative work with significant parts of the budget going in 3 directions. The first thing we hope to do is talk about and establish a proof of concept for an improved registry of catastrophic sports injury data. There's a significant, more than 30-year-old project at North Carolina that has been collecting data on catastrophic injuries. We think that we can go beyond that and improve upon it. At North Carolina, it tends to be aggregate data reporting coming out of it. We're talking about microdata and then doing all kinds of things to enrich the microdata, and we hope that will be more valuable. But we have to establish a proof of concept for this thing. Dan, did you want to say anything about AIM-1?
No, I think that's good.
Yeah, I mean, we've got a follow-up slide where we're going to expand upon it, so I'll wait till then.
Okay. AIM-2, this is, I think, in this field, I think this is incredibly innovative. I'm really pleased with AIM-2. We're going to take the patient records that we create from the pilot registry and enhance them with essentially longitudinal outcomes. Because at Sizer, we have access to and connections to the U.S. Census Bureau, Social Security Administration data, Medicare records claims data that are typically confidential, but with the right access and research proposal, you can become a sworn special status employer of the Census Bureau. That's what this ID badge does for me. And we can access these data, and we can actually find out when a disability claim comes in. We'll know their outcome. We'll know a lot of more information about them. And I'm really pleased with this. I think this will take the data that's available on this and sort of put it on steroids, which is just really exciting. I think there's a lot that we can do here. And then finally, Dan will be in charge of a mixed mode approach for contacting and follow-up. You can imagine that an environment where you're following up with patients that are catastrophically injured in a sporting event, you're going to have lawyers involved that say, you can't talk to them yet. It's not resolved. You're going to have parents who are upset. You're going to have differing versions. It was an aggressive hit. My kid didn't mean to do anything on the other side of the story. It's incredibly complicated, and I think that if we do really intensive follow-up, you could gather an incredible array of data that would be of interest to many researchers in many different fields. So Dan's going to be in charge of some of that, initially focused on sort of medical follow-up, but we could grow this thing in a variety of interesting ways. So Dan will be in charge of that on AIM-3. Okay, that's right. We did have slides on drawing out AIM-1 too.
Right. So these patient records, our inclination is there must be an administrative record existing somewhere because there's interactions, there's bills to be paid, so on and so forth. So if that serves as close as we can get to a universe of all serious injuries, let's start with those records. So a hospital codes up a medical record that's a part of the discharge record for every patient, and they send it on to the hospital association, who then sends it on to the State Department of Health, who then sends another version of that on to the Agency for Healthcare Research and Quality, and they're called the HCUP records. By the time it gets to the feds, it's been anonymized. It's a lot of detailed information. It's not perfectly anonymized, so it still has to be treated as confidential, but anyway, there's not the rich level of detail. So you have to go to the state level in order to get identifiers to be able to figure out where did this occur, where was the residence of the person, and in AIM-2, I'll explain why we need that kind of detailed information. So anyway, we've got two systems, MIDAS in Minnesota and Sparks in New York State, that form that kind of universe, the big circle, and in that big circle, for the purposes of this NIH proposal, it's focused on traumatic brain injury and spinal cord injury, okay? So all TBI and SCI. Then there's a subset of that are severe or catastrophic, potentially catastrophic, that we're interested in. And then there's another subset that are not displayed there explicitly, but implicitly, that are sports related, okay? The coding, our thinking is that the coding on the hospital discharge records is not as good as what the insurance companies do with the records afterwards. And if it's sports related, they're going to have a better chance of capturing that. So Mayo has this relationship with United Health, and we're going to be able to look at what did the state discharge record, the hospital discharge record that the state provides us with, how does that look compared with what United Health, assuming that United Health was the provider, the insurer, and kind of validate that coding at that point, and that it was sports related. So it's starting with this big net and just kind of narrowing down, and at various points taking pieces of information from different players in the administrative record to see, does this add information? Does this validate what we know about it? Dan, anything you want to add to AIM 1?
No, that all sounds good, especially just a good explanation of the relationship Mayo has, too, with United Health, which was unknown to me but was really kind of fleshed out during our meeting thanks to Hilal's knowledge and epidemiology here.
Yeah. Should we go on? Yeah.
From that, are you able to tease out, like, team-sanctioned, supervised sports versus just pick-up games and recreational activity, or?
Probably not. I mean, that's an excellent point. You know, is it pond hockey, or was it a formally organized where the coaches were, you know, level 4 USA Hockey, so on and so forth?
That's a terrific question. That's a direction I want this research to go in. When we met a couple of weeks ago in Rochester, Mike Stuart said, wait, that's a whole nother subject, and right now we just need the sort of catastrophic injury data. That would be terrific on its own. And so to avoid taking off, sort of, you know, biting off more than we could chew, we didn't go in that direction. I'll talk a little bit about the direction that might go, but you want to know everything from, you know, what rules were in place? Was it sanctioned? Were there referees? What were the training level of the referees? You could go in a million directions like that, which would be terrific from a sort of a sizer perspective, but right now it's sort of catastrophic injury focused.
The other very interesting sort of cleavage is sports recreation. Right. You know, at what point does a kid hanging upside down off the monkey bars falls on their head versus, you know, gets checked into the boards kind of thing. Let's go on to AIM 2. So this is the one that, you know, from a sizer perspective, really gets us excited. So we'll start that patient record as the initial entry point and then enhance it with a lot of other information. So we have had contact with folks in the Administrative Records Division of the Census Bureau who link census and survey records to federal tax information, to state unemployment insurance records, a lot of this kind of matching and linking. The major objective of the Census Bureau is to reduce respondent burden, that there's a tremendous amount of information that can be mined from administrative records, and by sharing or linking, and I hasten to add, under proper safeguards to protect the individual, because there's a lot of paranoia that, you know, government, big brother and everything. Anyway, so we start with, you know, and this is somewhat simplified, patient records that come from the state, they're confidential. We've got as much detailed information about the individual as is on the original record, okay? Then we take those records and give them to the Census Bureau. The Census Bureau has a relationship with the Social Security Administration, and the major beneficiary file to then identify, have these people been classified as having a disability for the purposes of Social Security. And then there's additional information about enrollment, about cost and utilization that can be further linked to that record. You have to be classified by the Social Security Administration as disabled for 2 years normally before you can get Medicare benefits for disability. So they can also access the Medicare records. Those are available from the Centers for Medicare and Medicaid Services. They're expensive data to purchase. We're hoping to save money because the Census Bureau is going to access them and do a lot of this work. And just stopping there, these are time stamps, right? That, okay, the injury occurs, person is hospitalized, they're discharged, that forms a record. We have information about where they lived, what the diagnosis was, a lot of information about them. Now, at a subsequent point in time, we have a Social Security record about that individual and their classification, and we get address and other information. And then 2 years later, we get a Medicare enrollment for those, who've gone through this whole process and wound up there. And we're assuming that, a large proportion, we don't know exactly what proportion, but a large proportion of people with catastrophic sports injuries are going to wind up with Medicare benefits down the road. We could look at all kinds of interesting things that, from the time that the patient record was generated, did the address change? Did they move closer? Did the family relocate to move closer to medical facilities, for example? You could do that with that kind of information. The last little shape over there, ARF, Area Resource File, that tells you about a lot of health service-related information at the county level. Contextual information, publicly available, but because we know the address, both at the beginning of this process and at subsequent Medicare, if there was a change of address, did they move to a county with a higher level of medical services, medical resources, for example. The American Community Survey, what we can do is, because we know the street address, we can geocode that and we can put them into a census block group. And we can say, this is a census block group that has a high socioeconomic status or a low socioeconomic status. Is there a disproportionate incidence rate of sports injuries depending on the kind of neighborhood that you live in? If you live in a poor neighborhood, does that mean that your school district or team might be starved for resources and you don't get proper training, you don't get proper equipment? A lot of, we're just throwing out sort of hypotheses here. But by adding all of that information onto that record, we think we have created a very rich, detailed characteristics and a time that, over time, what's happening to that individual. Questions about that? Okay. So aim 3, and Dan, I'm going to turf it over to you, is when not for that whole universe of injuries, but some subset, dive in really deep. Go ahead, Dan.
Sure. So currently what we're doing with our USA Hockey registry is that when we do identify through a variety of sources through our Google alerts or phone calls from either district risk managers within USA Hockey or perhaps physicians that are closely aligned with USA Hockey, such as Dr. Stuart, if they're deemed catastrophic, we have a pretty thorough questionnaire that we either mail out or, in the case that they don't want to complete it online, I'll phone them and then we'll complete it over the phone and then fax over some information for them to sign, letting them know that we're going to use it for research. And this was pretty important, especially for this research, because we have a questionnaire in place that really delves deep into the injury, the specifics of the injury as it relates to hockey, what equipment was being worn, was there a penalty called at the time of injury, was there a penalty missed, things like that. So this was interesting, but it seemed like it would take a lot of time to do on all the cases that we found. So this mixed mode approach to determine which is the most effective, whether it be a phone call, internet-based, if we were to do it in person, or if we could hand mail it and have them send it back, is what we propose to do once we've identified a handful of cases where further information gathering is needed. And I think that this will help improve response rates because, like Bill talked about earlier, some families don't want to get in touch, or there's litigation involved, but also, it might be uncomfortable to do either over the phone, or they'd rather talk to somebody in person, face-to-face, to kind of get a feel for, those collecting data, whether or not it's I guess, being collected for a positive change in the injuries that have occurred during a variety of sports. So to have this kind of multifaceted approach to begin with, and then determine which is the most effective based on the response rates, is going to provide a lot of power for this study as far as collecting information. And someone asked a question about, and I forget what it was just a few minutes ago, but I think that the way that we collect information once we go further into, which Dr. Stuart has kind of cautiously warned us that isn't necessary at this point, because there's tons need to be determined from mechanism of injury and different, what sports are and how the players are being injured through what mechanisms. But to get at the rules in place and, the level of officials like Bill was talking about, this is a direction we can go and can only be enhanced with higher quality surveys once we determine if they need to be either sport-specific or the injuries aren't broad enough to do one broad survey. They're very specific to either TBI or SCI at this point. So we'll need a specific survey for both injuries. But to delve deeper, like Bill was talking about, we'll probably eventually need to do a more sport-specific, injury-specific survey based on the trends that we determine and that we find over the course of this discharge records search. So I'm really excited to continue this role, because it's, some families are really willing to give this information to you because they're so concerned about not only their child but also the sport, and they're never, in my experience, they have yet to be jaded by the sport of hockey. They're just concerned about, what happened, how it happened, whether or not there's going to be options for their child as far as some question insurance issues about payments back, and we're able to kind of triage those to the right people because of our involvement with USA Hockey. But it's very interesting to just hear the responses and read the responses from families that are dealing with such catastrophic injuries, and I'm glad that we can continue this going forward and include other sports, because it's going to be very, I guess, eye-opening, I would think, to see what's happening in different sports and what the outcomes are. So it's going to take, it's a smaller portion of the whole proposed study to NIH, but I think it's the one that might take the most time just because of the amount of work it takes to follow up and contact these individual families.
Yeah, I think in this R21 we propose to follow up with a subset of the total number that we find in New York and Minnesota, and that may be measured in sort of 150 people in each state or something, and then we'll propose to try to follow up with 10 in each state or something as far as assessing which mode they appreciate the most. It's clearly going to be expensive to do that kind of work. So in the interest of time, let me turn quickly to where we think we might go. We've got that R21. It's we're going to polish it up over the next few days and get that in on by Tuesday. The first thing we have to keep working toward, though, is a national registry. We have to serve, athletes like Jack, for sure. That's, I think, the number one priority. Now, as I said, I'd love to see a lot of other kinds of data gathered. You've got psychological factors, family, community effects. You can inform rules changes. There's just a ton of things you could do. For example, we know in this particular case, the athlete that hit Jack has left hockey. So what is the impact on him, his family? What is he thinking? How is he doing? All kinds of hockey moms out there are now dropping their kids off at the hockey rink in Minnesota after this event, thinking, is my kid going to come home, safe? We don't know anything about, has anyone ever really studied, like, what happens to the teammates of a catastrophically injured player? Do they have a different future in their sport? Do they leave it for another sport? Do they stop playing altogether? That kind of thing. We don't know. A ton of stuff you could do with referees, interviewing them, training them, figuring out at certain training levels and certain clinics that you give, do they have an effect on reducing catastrophic injuries? Coaching. Do coaches, is there training and advice you could give in terms of how they implement their game? There's a ton of work that could be done. Very importantly, we're also working on a completely tangential project. It turned out that I was speaking literally to a friend of mine and he runs a company called Motion Intelligence. It's located in Ithaca. And he thought, wow, I could make use of some of this collaborative team you've put together. He's working on a project that will deliver solutions for understanding concussion injuries. So force in a helmet, force in non-helmeted sports, things like that, concussion measurement. And he's working with a group of researchers at Wayne State University, probably the leading researchers in the country on understanding impacts in the automotive industry and in the military. They've got this amazing model of the human head and all of its densities and structures and bone and fluid and 250,000 data points on the human head. And they know that if you take a hit here, how that force is transmitted through all that material, you know, using like high-speed computers and doing that sort of analysis. They're part of his work. And what Motion Intelligence is trying to do is build a solution that can measure an athlete's experience, the concussion forces in, you know, in this example, a helmet, transmit it to the cloud. Ultimately, you can see a huge application for medical research growing out of that, as well as clinical care. You could really inform those things. Our role, of course, would be we'd help with the data on this, and that's a real exciting tangential opportunity that Sizer has. To this end, we have submitted 2 proposals. We submitted an application. Well, we submitted 3 proposals. We submitted one to the Cornell Population Center, and we're thrilled to get graduate research assistant funding for a semester to work on this. And what we're trying to do is build, in this case, a national registry of traumatic brain injury data. And the really amazing thing is you could go from the actual event where you'd know the concussion forces all the way through to the patient outcome, which that would be revolutionary. Right now, the best you've got is, you know, a doctor asks a series of 20 questions after an event. You don't know anything about what happened really in someone's skull, in brain. Secondly, we have submitted a $500,000 proposal to NSF. That's currently undergoing scientific review. I think the review started on Tuesday. And third, we submitted to the Bronfman Better, but I understand why they didn't give us money 2 years in a row for a related project. We did not receive that money.
But we still asked.
Yeah, we did ask. It seemed worthwhile asking.
They can only say no.
It's a terrific proposal, but I can see why that wasn't funded. And so, most importantly, we're going to submit the R21, and we'll go from there. NIH money's hard to get. I think it's a good idea, but I'm always sort of pessimistic with these kinds of things. We'll see where that goes. And finally, I just have to stick the shameless plug for Sizer Services. We've got computing and data resources, you know, a lot. We're really great at this. I've got really great staff. We're so excited. You can see that from this. Like, we work with all kinds of data. And if you have a data project that you need help with, we would love to help. We are really good with documentation, data manipulation, analysis. We're thrilled. Data are erupting everywhere, and we're right in the middle of it all, and it's so exciting. So I'll just leave it at that. Let me talk about a couple. With Sarah Giroux, Parfait, and Lundu Onyege, we just submitted on Tuesday a proposal to the Gates Foundation to work on integrating some African demographic and social and health data from national level down to community level. It's sort of a Gates game-changing kind of proposal. I don't know how game-changing integrated data is, but that was what the call was about. So we submitted a proposal on Tuesday. Very neat. Jeremy Williams, Sizer developer, is working on the Freedom on the Move project. It's a project led by Ed Baptist to digitize 19th century runaway slave ads. So you can see we're working with concussion measurements, slave ads, African data. We've got data down cold. So I'll stop the plug there. Thank you. Any questions? We're happy to stay after and chat or take questions.
I'm curious, what's the closest sort of registry that exists presently to what you guys are working on?
There are TBI registries in a couple of different countries that we are. One of the first things the graduate research assistant will do, and we're hiring, by the way, for anybody who's interested in this kind of thing, spread the word. We're looking for a really good graduate student who's really excited about this project in particular. Those data repositories exist, But the revolutionary thing that we proposed that I think is revolutionary, and it is, to NSF, I don't know if I'll fund it because it's a very health-related proposal going to NSF, is that both Motion Intelligence and a number of other companies are trying to solve the problem of how do you measure concussions. The NFL would love to see that problem solved. You know, they've sent money to NIH to work on it. If we can pair actual data on a concussion event with diagnosis, treatment, and outcome data, that would be incredible. Because currently I saw a terrific quote the other day that our ability to understand and treat traumatic brain injury is archaic. Like you may have a student that's hit in the part of the brain that affects speech, and the doctor's looking to see if the pupil's dilated, right? You don't. But if you had good data about where you were hit and where the force was distributed, you could revolutionize treatment and understanding of the disease. And you know, sports in particular are incredibly difficult when it comes to concussions, and this is the sort of hook I pitched to NSF, was the culture of sport. Everybody wants to pretend concussions don't exist. The star player doesn't want to lose his spot on the starting line. The parents are looking to that college scholarship. The coach doesn't want to pull his best player. All these people are involved and have an incentive for, de-emphasizing the problem. And there's really good research that says, concussions in sport are underreported by a factor of 7. And then we don't know the effect of repeated small blows, right? That's an really open, hot topic today. Much less the big, blows, which are obvious, like that person is concussed and they can't stand up or they're nauseated or vomiting, right? And that whole range is of concern to parents and doctors all over the country. Yeah.
So you had 45 catastrophic out of how many players? I'm just trying to figure out what the tiny percentage of the number of ice hockey players.
Thankfully, catastrophic injuries are a small percentage. So, Dan, I don't know if you could hear the question. The question was you had 45 catastrophic injuries in the USA Hockey database. Mm-hmm. Of what, what's the denominator on that fraction? 45 out of how many? About? I don't.
Oh no, 45 total entries. So all of those weren't catastrophic. Okay. 45 entries that came across our Google alert for hockey injury over the course of 5 years were collected, and I believe it was well less than that. I'm pulling it up here right now, but I think it's 11 that were catastrophic, and of those 11, 2 of them were instances where a puck was hit in the player's sternum, causing the heart to stop and causing fatal cardiac arrest, and then another one of them was a death that was totally unbeknownst. There was no mechanism of injury. It just occurred while playing hockey, and a recreational adult player had sudden cardiac arrest and died as well. So the number of actual catastrophic injuries in the last 5 years in the United States that were made publicly available, I guess, that made the news, any kind of local news, ESPN, anything like that, was 10 or 11, and which is good because they're not as frequent as, since they're so severe. The bad thing is the way that we're trying to collect this data currently in my research area, it's very incomplete unless it makes the news and unless those participating in that injury are willing to follow up. So we get a very crude picture.
Dan, do you know how many people play hockey in the U.S.? USA Hockey would know that.
Yeah, they would.
But I think we don't know the exact proportion, but thankfully catastrophic injuries are rare. The unfortunate thing is when they're catastrophic, they're devastating for an individual.
I'm wondering how that might compare to like football and something where other people.
Well, and that would be one of our purposes of our activity, since we're going to go across all sports. And one of the concerns, and Dr. Stuart raised this, is the parent who pulls their child out of ice hockey or football and then they go skateboarding. And he said that there's evidence that any activity involving a wheel is far more dangerous. So, trying to start to put some numbers on these activities.
Yeah, the NFL is very concerned. You read in the paper weekly about the mom who pulled her kid from youth football nowadays, and the NFL, in fact, funded the R21 opportunity. They're very concerned about traumatic brain injury and spinal cord injury.
Bill, the number's 511,000.
Okay, thanks.
So.
People that play ice hockey.
The interesting thing is, of course, the Mayo effort doesn't include Canada, and there are a lot of hockey players in Canada. In fact, there are 11 times the number of hockey rinks in Canada per capita than in the U.S. USA Hockey actually thinks anywhere in the world, the biggest opportunity to grow the sport of hockey is in the U.S., not anywhere else. It's amazing. There's a lot of opportunity to grow hockey. Thanks, everybody.
Thank you.